Today we're going to be discussing TFOS DEWS-II in clinical practice. I'm Dr. Whitney Hauser. I'm an associate professor at Southern College of Optometry. I have some financial disclosures for you to review. These companies may or may not be discussed in the lecture, but I wanted to offer them for your review. I'm also the editorial board member for Primary Care Optometry News, as well as a columnist for Optometric Management. In addition to my role as consultant for companies, I'm the founder of Signal Ophthalmic Consulting and DryEyeCoach.com. If you have been reading journals recently, you've probably heard the word DEWS-II and TFOS DEWS-II. What we're going to do is sort of break down some of the clinically relevant pieces of that. The document itself is very, very robust. It's a significant report, and it's going to take some time to sort of go through each of the different sections. So again, we're just going to hit some of the highlights from sort of a 30,000-foot overview. Our objectives today are to update the definition, classification, and diagnosis of dry eye disease, critically assess the etiology, mechanism, distribution, and impact of this disorder, and address its management and treatment and therapies. So what are the categories of the DEWS-II report? Again, very lengthy document, and it really deserves some time to review. The definition and classification. The definition, as we'll talk about here in just a moment, it's really evolved over the last 20 years or so. Sex, gender, and hormone considerations, epidemiology, tear film, pain and sensation, which the document goes into beautifully, pathology, iatrogenic dry eye, diagnostic methodology, management and therapy, and then clinical trials. So what was the definition before we get into our current definition? Where did we begin this journey? In 1995, the definition was dry eye is a disorder of the tear film due to tear deficiency or excessive tear evaporation, which causes damage to the inner palpebral ocular surface and is associated with symptoms of discomfort. And you know, if you read that at face value, even today, a lot of that seems to hold true. However, we often see patients that don't necessarily have symptoms of discomfort. So from that classic definition, would those patients be true dry eye patients? So let's see how the definition changed in 2007. So when the DEWS original report was published in 2007, the definition changed a little bit. And what they initially had said was sort of a very straightforward definition of dry eye, sort of evolved. And the evolution of it, for me, with a key change was the fact that they added the word multifactorial. If you treat dry eye disease, you know that it's very rarely one thing. Usually there's several factors at play, and failing to address any one of those factors can fail in the patient's, opportunities for improvement. So the definition in 2007 was dry eye is a multifactorial disease of the tears and ocular surface that results in symptoms of discomfort, visual disturbance, and tear film instability, with potential damage to the ocular surface. It is accompanied by increased osmolarity of the tear film and inflammation of the ocular surface. So we're not only seeing that multifactorial portion of it, we're also seeing the increase in osmolarity and inflammation now making their way into the definition. So it's a little bit more complete in 2007. So where do we go from there? So in 2017, when the DEWS-II report was published, the definition now reads, dry eye is a multifactorial disease, so retaining the multifactorial nature of it, of the ocular surface, characterized by a loss of homeostasis of the tear film and accompanied by ocular symptoms in which tear film instability, hyperosmolarity, ocular surface inflammation and damage, and neurosensory abnormalities play etiological roles. So this is a new piece, having that neurosensory abnormalities. So what are the causes of dry eye disease? Just giving, again, very high-level overview. We're going to go through a few of those. Now, granted, there can be certainly far more than we're going to see in this list to have a real comprehensive review, but some of our more common causes are inflammatory disease, environmental conditions, hormone imbalance, contact lens wear, neurotrophic deficiencies, medications, as well as eye surgeries. Now, classically, dry eye disease, this was published in Cornea in 2012 by Limp. It really broke down and said evaporative dry eye disease took up the lion's share of our patients who have dry eye at around 86%. And then the aqueous deficient portion was closer to 14%, so a much smaller piece of the pie, if you will. Now, while Limp's study did talk about the overlap of evaporative and aqueous deficient, more or less a mixed mechanism, it definitely had sort of percentages of who would be your patients at risk for evaporative versus aqueous deficient. So what we're seeing is changes in our dry patient population. And this is also addressed in DEWSII, the trending dry patient. We're seeing newer demographic, a younger demographic. We're seeing more gentlemen in the mix than we have before. And what is at play there? It's possibly things like modern risk factors, digital device use. Americans are using digital devices anywhere between 6 to 10 hours a day. So patients are oftentimes having incomplete blink because of digital device use, and that can make an impact. Surgical considerations. For our cataract patients, they're likely to go up one level of dryness postoperatively, and for our LASIK patients, they're likely to go up 2 levels of dryness postoperatively. While that may be temporary for most of our patient population, some of them can have long-term complications post-surgery. Contact lens use can play a role, as well as cosmetics. Cosmetic role is not fully elucidated at this time. We don't know exactly what role that does play, but there's a certain level of toxicity that's associated with some cosmetic products. Now, there's a digital device survey, the National Eye Care Survey, that was completed in 2016. And if you look at the information on the slide, the information on the left-hand side is answers among eye care providers in the survey. Information on the right-hand side is about adults' responses to their dry symptoms. So when we look at that information, eye care providers, 92% of them believe that the use of modern technology contributed to dry symptoms, and that's probably not a shock, and that's a high percentage there. But what we really need to notice is that the adults with the symptoms of dry eye, 79% of them said they were more aware of feeling their eyes after viewing a screen. And when you're using a screen 6 to 10 hours a day, that's putting the patient at risk again for dry eye and those symptoms of dry eye. 59% of them noted using a screen is challenging as a result of their dry eye. And perhaps really what's the most important takeaway from the National Eye Care Survey is 87% of eye care providers say that in today's world, there's not one typical dry eye patient. You know, it used to be when I looked out into my waiting room, I could really pick out, just by demographics and appearance probably, the patient that was at greatest risk for dry eye. You'd see a 50 to 60-year-old woman out there, just a little bit of glassy-eyed, maybe a little bit of redness, maybe a little epiphora, blinking frequently, things like that. And you could just sort of, ascertain from demographics who your risk factors were for your patient. Now, it's just not that way anymore. It's different. And it can be, again, gentlemen, it can be younger patients. My youngest patient in clinical practice with dry eye is 7 years old. So you just, again, have to be really open-minded in clinical care of who may present with dry eye. Some of our diagnostic considerations through DEWSII is triaging questions. We want to be asking the right questions to cast a wide net to then bring those patients in and be able to drill down into their symptomatology. We go into risk factors, diagnostic tests, subtypes of classifications, going through steps 1, 2, and 3, and 4. So in TFOS DEWS, some considerations. The document really beautifully illustrates, if you have an opportunity to go through and again, not only read it in full, but also look at some of the illustrations or diagrams that really give you a nice, quick overview of some of the content. There's one illustration in particular that has a flow chart, and it breaks down a patient presents in your office, and it allows you to go through the symptomatic versus asymptomatic branch and then further down the food chain. So what we're going to do is more or less be breaking down some of that document and that illustration. So patient presents to the office. A patient may be asymptomatic or may be symptomatic. And then we're going to classify the disease and begin to assess the symptoms and look for ocular surface disease. To look at symptoms, we need to have something that's going to give us a number, going to give us a quantification. Validated surveys like the Ocular Surface Disease Index, or OSDI, the SPEED survey, and the SANDY survey are great opportunities to give a quantitative analysis to qualitative symptoms. Now, when you're in clinical practice, you probably think, gosh, that's just what I need, one more thing to have my patients fill out. And I understand that it can take a little bit of time. Certainly the speed test is a little bit faster, as the name implies, maybe than Ocular Surface Disease Index, and a little bit easier to score as well, so for your consideration there. However, the reason that it's important to give a number to symptoms is, a lot of times our patients who have dry eye disease can concurrently have problems with depression and anxiety. It's been shown in research that that patient population does have higher prevalence of depression and anxiety in their life. And if that's going to be a reflection on their symptoms and sort of affect how they are telling you they feel a certain day, we want to be mindful of that. And giving a number to it can actually sort of wash out some of those things and really drill down into what their true symptoms are that particular day. Now, additional options, while not validated, there are some questions from the Dry Summit of 2014, and these are beautifully composed questions. And those questions are, number one, do your eyes ever feel dry or uncomfortable? Number two, are you bothered by changes in your vision throughout the day? Are you ever bothered by red eyes? And do you ever use or feel the need to use drops? Those questions, again, not a validated survey, but if you add those questions in to your intake, with the technician, or if you're doing your own case history, you're probably going to capture a lot more dry patients than just saying, do your eyes feel dry, or how do your eyes feel today? And then you can move on from there and do a validated survey as you follow the patient. Other considerations from DEWSII. Once we have our patients that are either considered symptomatic or asymptomatic, we can go down the food chain a little bit further. In symptomatic patients without clinical signs, they do not fall into the dry group, but are differentiated into preclinical. So the patients who say, gosh, I just don't feel good. My eyes don't feel good. I feel like my eyes are dry, irritated, what have you. But when you look in, you don't really see any clinical signs, nothing, no SPK on the slit lamp, no diagnostic testing that's validating their complaints. These could be preclinical dry patients. They're on the road to having dry eye. Or it could be a neuropathic pain patient. When we have patients with diagnostic mismatches, it's very easy to want to classify those patients as, they just don't know, they don't make sense to us, their complaints aren't authentic, but really it could be a neuropathic pain. Now we have to be cautious about classifying a patient as a neuropathic pain patient until we really identify whether, from a diagnostic perspective, there's no sign information that we can ascertain that validates what they're saying. Make sure they aren't that preclinical patient. We don't want to be too hasty in putting them in that neuropathic pain category without proper analysis. For our asymptomatic patients who feel fine, but they're exhibiting signs, are differentiated into patients with either poor corneal sensitivity, perhaps your long-term contact lens wearers, or prodromal signs, who are at risk of manifesting dry eye with time or provocation. So for the physical examination, we want to consider what, really entails the physical examination. So a lot of times what is often overlooked is visual acuity and intermittent blur. I often talk to colleagues, and not only just colleagues in optometry and ophthalmology, but also our staff members and technicians. And I ask them, if you have a patient and the patient's asked to read the lowest line they can on the acuity chart. And the patient starts to read, and they read TZV, and they pause. And then I'll ask the technician or the doctor, what do you do next if they pause? And inevitably, the answer is an immediate response. And their immediate response is, I tell them to blink. And then I ask, well, why did you tell them to blink? And the reason always is it makes them see better.